Good afternoon. I'm Mickey Hart, ambulatory and microbial stewardship pharmacist at Freighter Health. This concurrent session will be offered as continuing education credit for pharmacists, and Dr. Caitlin Marcus and Dr. Jonathan White will be presenting the shrinking role of beta blockers in aspirin, a focus on opportunities to deprescribe. Caitlin Marcus earned her Doctor of Pharmacy degree from Drake University in 2020. She completed a PGY1 pharmacy residency in the ambulatory care setting at Freighter Health, as well as a PGY2 ambulatory care pharmacy residency at Freighter Health in Milwaukee. And since completing residency, she's been a clinical pharmacist in primary care, as well as the residency program coordinator for PGY1 and PGY2 pharmacy residencies in the ambulatory setting at Freighter. And just back from the Olympics in Paris, but with no medals, Jonathan White is a clinical pharmacist in heart failure at Freighter and the Medical College of Wisconsin. Jonathan completed his PharmD in 2008 from Midwestern University College of Pharmacy in Chicago. And he completed PGY1 pharmacy practice residency at St. Alphonsus Regional Medical Center in Boise, Idaho, followed by his PGY2 ambulatory care and academia residency at the University of Colorado School of Pharmacy. Before joining Freighter in 2018, Jonathan practiced in internal medicine and endocrinology in Portland, Oregon. And in addition to his clinical responsibilities, Jonathan is the program director for our PGY2 ambulatory care program at Freighter. Additional information about each of our speakers can be found in the PSW conference app. And please help me welcome my friends, our speakers.
All right, well, thank you for the introduction, Mickey. I'm gonna probably walk around a little bit up here, so move that down. Probably good height for you too. All right. Appreciate the introduction from Mickey. It's always nice, these meetings, you have a lot of nerves coming up here, but to get introduced by someone you know is always a little bit calming and relaxing. So Mickey already covered the title of our presentation, but thought I'd just mention that there's a lot of information today, and we realize that we are the post-lunch session. And so being thoughtful of that, we are going to kind of veer a little bit more towards the active learning in the second half as Caitlin picks up for us with more of the aspirin discussion, whereas I'm going to start and talk about the clinical trial evidence for beta blocker utilization. Caitlin and I do not have any conflicts of interest or disclosures before we get going. And as I put up the objectives slide here, I did want to take a moment just to talk about where this presentation come from and where the idea came to kind of submit this as an idea for this particular meeting. And there was really two of them. So one of them is that, so I practice on the Ambulatory Care Advisory Committee. And for over a year now, there's actually been a series of podcasts on deprescribing. We're going to talk a little bit, I'm going to definitely preach a little bit about pharmacists' role in deprescribing today, but it's really great. So go to the PSW podcast, the AmCare series. I believe it dates back to like a PPI deprescribing podcast. There's an aspirin one from last year that's a really good addition to what Caitlin's going to prescribe. And there was one that was just published on statins on August 3rd. The other is actually our first objective for today, which was the Reduce AMI study, which made some waves when it came out this spring. And in a rare opportunity where I submitted a presentation and more literature has not come out since that time, I can actually give you the most up-to-date information and tell you about some stuff that's going to be coming down the pipeline in the coming years. Our other objectives today are going to be focused on aspirin. What remaining indications do we have? And what are some situations where we may need to revisit aspirin pharmacotherapy? And hopefully throughout this, you walk away with some pearls on chart review. No matter what your practice setting is, we do need to be identifying these areas to revisit pharmacotherapy. But before we get into that, does everybody remember, and I hope I see some nods here, niacin? All right. So niacin, or extended release niacin. I studied this medication when I was in school, 2006, my lipids unit, lowers LDL, lowers triglycerides, raises HDL. It's like the only medication that raises HDL. And I thought, this is amazing. Everybody can deal with a little bit of flush, right? Well, fast forward a couple years, I'm a new practitioner, and these two studies come out effectively kind of killing niacin. There's our tombstone for niacin because it fell down the guideline and eventually off the guideline. But some trial evidence reinforced this change in practice. What about around that same time? I was also in school at this time, and these became a member of every patient's profile, inpatient and outpatient, because it was billed as the panacea for heartburn prophylaxis. The commercials wrote themselves, the academic detailing was fantastic. Until the literature caught up with chronic use being related to things like dementia and CKD. And this literature actually continues to evolve. So much so, we did a podcast on it, and there's an entire section of deprescribing.org dedicated to this. because of the rebound acid hypersecretion, which also happens. So, all right. The list goes on. Whether you've been practicing pharmacist for a year, 2 years, or many more, you've seen this graveyard of medications. Vioxx happened when I was a first-year student, right? So this is going to continue to happen. And this is why our role as pharmacists is so important. We can be a catalyst for these discussions. We all agree that we're supposed to be members of the healthcare team in prescribing appropriate pharmacotherapy, appropriate monitoring of that therapy. No matter what setting you're in, community, ambulatory care, inpatient, long-term care, consultative, this is our role. Our responsibility is to remain up to date and to be able to stay current. When a medication does fall out of favor, we follow that literature and are able to support that revisiting of that pharmacotherapy, like I said, being a catalyst for those discussions. And with that, I introduce Ken. Ken is 74 years old. He had an NSTEMI about 7 years ago, has some comorbidities and diabetes and hypertension. I'm not going to read the medication list. I think it's fairly readable for everybody in here. His blood pressure is well controlled. And Ken looks at you as his pharmacist in whatever setting you're practicing in. And I think we've all heard this question. I am on too many medications. What can I get rid of? And I've heard this from a lot of patients with many longer lists than Ken here. But a lot of times over the years when I've reviewed a patient's profile, and we pharmacists, a lot of times we start with the medication list and kind of work our way backwards. A lot of other disciplines go the other way around. But I think everybody I've talked to, student, resident, physician, APP, has all said, oh, they're on metoprolol, heart disease, we're good. Let's leave that there. Low-dose metoprolol, never been titrated. This patient has probably been on this since 2017 upon discharge, never been revisited. So this beta blockers generically for heart disease, where did that all come from? How did it get this flag where it staked claim on every patient's medication list of being this permanent lifelong therapy? Well, we have to go back pretty far to kind of figure out how we got here. So these are some of the landmark trials that came out that showed beta blocker after myocardial infarction was beneficial for not only reinfarction, but also decreased cardiovascular death. So pretty significant outcomes there. So significant that the Center for Medicare and Medicaid Services, which steers a lot of prescribing by providing reimbursement for meeting metrics, put together a metric that if your hospital patient gets admitted with a myocardial infarction, they better leave your hospital on a beta blocker, and you better start it quickly while they're there. Which at the time made total sense, right? Because beta blockers were a great way of decreasing oxygen demand in the cardiac tissue and also decreasing the adrenergic effects that are occurring during myocardial infarction. Check, check. Those are great reasons to use a beta blocker in that setting. So also around this time, 1980s. So these studies, I did want to highlight really quick before moving into anything else. These studies came out 40 years ago. I was born in 1982, so these have been around as long as I have. All right. The other thing happening during this time period was the hypertension guidelines supported the use of beta blockers over other therapies. I put this little snip in there because I kind of love how JNC 6 reads. It says, after appropriate lifestyle changes are enthusiastically promoted and strongly encouraged, drug therapy will be needed for most patients. So it's kind of like this, yes, let's do this, but you're going to need a medication anyway. And that medication at the time was recommended to be a diuretic or a beta blocker. All right. So this was the pre-reperfusion era, and a lot of things have happened since that time. Door to balloon. Has anybody heard that terminology before? Okay, I see a lot of nods. So that's like patient enters hospital with a myocardial infarction. How quickly can we get them reperfused? We're not doing that with medications anymore. We're doing that with devices. We're doing that with PCIs. And the quicker we do that, the faster we get oxygen to the cardiac tissue, the better those patients do. There's also been longstanding use of antiplatelet medications, particularly for secondary prevention. The wider spread use of statins, ASCVD reducing medications like RAS inhibitors. Well, the data for beta blockers, when revisited, stopped looking so good. So instead of looking at beta blockers for this generic like heart disease and stable coronary disease, we really have to break up beta blockers into its many cardiac indications. And so let's take a look at all of these, right? We're going to kind of rattle through some of this. So upper left-hand corner here, we see heart failure. Near and dear to me as I practice in heart failure. And I still have every student and resident on rotation read the Merit Heart Failure Study, which came out 25 years ago, because that's a class 1A recommendation, or what I would call, that's a slam dunk indication. You use that medication for that patient population and you titrate it just like they did in the studies because it reduces cardiovascular death and saves lives. Cardiac arrhythmia. There's a lot of checks here. So check, check, check. It has a mechanism, rate control for arrhythmias, prevention of recurrent arrhythmias, has data for mortality, and does have the guideline support for its use. Once again, we have another slam dunk indication. Going to the lower right with angina, this recommendation has changed, and it's worth pointing out that this changed recently. So in 2012, the guideline for stable ischemic heart disease gave preference to beta blocker over other anti-anginals. Kind of said, use the beta blocker first. If you need to use the other pharmacotherapy, that's fine. Fast forward 11 years and many trials later, the playing field is level. So the authors of the chronic coronary disease, because they had to change the acronym again, enforces using a therapy that the patient will tolerate, that they can take, and that they will continue to use. And so it actually gives no preference to beta blockers over centrally acting calcium channel blockers or other anti-anginal therapies like long-acting nitrates. So more of a benefit risk discussion for those patients. And then as I mentioned, JNC6 earlier just because of the timeline of that, but it really was JNC 1 through 7. 40 years of antihypertensive therapy favored beta blockers as first line. And in 2014 through now, beta blockers have actually fallen to later line pharmacotherapy for hypertension. I hope this isn't new information for anybody in the room, but really the main time we're using beta blockers for hypertension is when there's a compelling indication like those that are kind of on the screen. So where does that leave us? That leaves us with this post all myocardial infarction indication, which is what we talked about earlier with an NSTEMI or STEMI, and then patients with stable coronary artery disease. That's that beta blocker that laid claim on that medication list, is that it's here forever and here to stay, and you're not going to discontinue it. So the trial data keeps on going, as I hinted earlier. So this study was the COMMIT study, came out in 2005, and it was kind of the first to really poke a hole in kind of ubiquitous beta blocker use around the time of myocardial infarction. So as you can see here, the results of starting metoprolol quickly upon admission and then titrating and discharging on oral metoprolol really did not result in any significant improvement in all-cause mortality. And even when they looked at the composite outcome, which is kind of like that catch-all, let's get the data, no benefit there either. There were some key secondary outcomes that actually did have an impact on the guidelines at the time. There was this risk of arrhythmia mortality, pretty big number needed to treat of 200 patients, but there was also this increased risk of cardiogenic shock within the first 30 days, which now enforces if patients appear that they're at risk for developing that, we are holding on the beta blocker and delaying that pharmacotherapy in those patients or avoiding it. Fast forward a few more years, we have the REACH trial. So we just looked at COMMIT, which is around the time of the infarction. The REACH trial looked at actually kind of more that stable coronary disease, kind of that longer term pharmacotherapy. I like the REACH trial because, I work in cardiology, and the benefit of that is that I get these trials that have 45,000 people on them, right? There's a lot of other disciplines my colleagues work in, they're like, oh yeah, the N was 200. I'm like, all right, hard to make decisions based on that. So they had, roughly 14 to 18,000 patients between known prior MI, known CAD or CAD risk factors. And I'm not going to belabor any points here. They also did not show any significant difference in a composite of CV death, non-fatal MI, and non-fatal stroke in patients that were either on beta blocker or not on beta blocker. So this was a cohort study. All right. So just like any other time period where we start getting a culmination of literature, someone says, we need a meta-analysis. We got to look at it all together. So they looked at this, and I realized as I was developing this slide, I'm like, man, I just put a lot of numbers on that slide. So I kind of broke it down with green and red. So hopefully everybody can see this. But you can see the reperfusion era. I love the way they did this because those were studies before door to balloon, before PCI. And on the right side is the reperfusion era, so more modern management of a myocardial infarction. We can see that CV death went away, right? We saw that in the REACH trial, so that's confirmed here. The recurrent MI and the recurrent angina stayed significant. They stayed beneficial for beta blockers. The risk of heart failure was higher. The risk of cardiogenic was higher with beta blocker use. And drug withdrawal across the board for beta blockers was pretty high because a lot of patients stopped these therapies. I think, anybody who's worked with a patient on a beta blocker, we can certainly see some reasons why they would stop that medication. So there's always questions. There's always questions that remain. And that's why we keep on doing what we're doing. That's why we keep on looking at the evidence. So with this no risk, no difference in cardiovascular sudden death, but there was this lower risk of recurrent MI and better angina management. So who benefits and how long should that therapy be continued? How do we stratify and how do we get the therapy to the right patient, right? There's that triple aim. And then for patients who may not benefit post-MI, who are those folks? Like, what does that population look like? So we look more recently into the data further. So this came out in 2021, and this is an important trial. It was a South Korean cohort study where they looked at 12,000 patients who were prescribed a beta blocker or not at discharge. They looked at, this is a more modern study, so we're looking at composite outcomes. And there was a benefit, a significant benefit. The hazard ratio was 0.84, less events in the patients that were treated with beta blocker. But the smart thing that this trial did is it stratified by ejection fraction, and they saw a significant interaction. Light bulbs go off. We have this benefit when we have that comorbidity of a reduced ejection fraction. Even mid-range ejection fraction benefited, but we lost that benefit when ejection fraction was what we call preserved or 50 or higher. What about duration? So that was kind of a shorter term study. So like immediately following myocardial infarction. Well, the Swedish cohort study of 43,000 patients, getting a theme here, right around 45,000, right? So also the Swedish trials are great because they have these great databases that they utilize, and then they can kind of do all these lovely trials from them. So this looked at patients with a history of MI, but they looked specifically at patients with that preserved ejection fraction. The follow-up started 1 year after MI and went all the way out to 4.5 years. And their primary outcome was the composite of all-cause mortality, MI, but they also included a hospitalization for heart failure because we're using beta blockers. If we can show benefit here, that's a morbidity type situation preventing progression. So they wanted to look at that. And after adjustment, the benefit just wasn't there. So once again, this kind of confirmed short-term after MI with preserved ejection fraction, longer-term after MI with preserved ejection fraction, we're not really seeing the benefit. So this resulted in a pretty significant change in a guideline that came out last year. Like I said earlier, the CCD, not SICD, the CCD guideline. And these are now the recommendations. So you can see my slam dunk theme here. So we know about this indication, patients with reduced ejection fraction and chronic coronary disease, absolutely, we're going to use a beta blocker. Level 1A evidence also for patients to use metoprolol, succinate, carvedilol, or bisoprolol if the EF is less than 50% and they have chronic coronary disease. So really, this is kind of like that, let's not use non-cardiac beta blockers in this patient population. So if they're using it for this indication, they're on a different one, that's another discussion we need to be ready to have. We get on here, a little bit lower level of evidence. This is a 2B BNR. NR stands for non-randomized trial data supports this. So this is in patients with chronic coronary disease who were initiated on a beta blocker for a previous MI without a history of a low EF, less than 50, and without any of the comorbidities we talked about earlier, the other indications we talked about earlier, like angina, arrhythmia, uncontrolled hypertension, it is reasonable to revisit that medication for long-term use beyond 1 year. This is a pretty decent change, right? So the data is getting potentially not super beneficial. So maybe we kind of revisit pharmacotherapy after a year of use. And then lastly, this is a no benefit recommendation. So this is kind of like that nail in the coffin for like where we just don't use this. So in patients with CCD without prior MI or an EF of less than or equal to 50%, the use of beta blocker therapy is not beneficial in reducing MACE in the absence of another primary indication. So sorry for just reading a slide to you, but that's kind of like that baseline recommendation. So let's look at this one a little bit further because this is where kind of like that first objective came in today. So non-randomized, but now we actually have a randomized trial. So we're going to briefly talk about the REDUCE AMI trial. This trial came out this spring. It was published in the New England Journal of Medicine, and it looked at beta blockers after MI in preserved ejection fraction. So it was 5,000 patients, another Swedish study. Like I said, we looked at preserved ejection fraction following an MI. These patients did have to have angiography so we could review their ejection fraction. It was randomized controlled. I will point out this was open label, and they used metoprolol or bisoprolol or no beta blocker whatsoever. So so it's open label. The bisoprolol, remember, bisoprolols are like hypercardioselective beta blocker, whereas metoprolol is going to lose some selectivity as we get to higher doses. That's kind of the major difference. And then bisoprolol is a little more commonly used in Europe. The median follow-up was pretty long. It was 3.5 years for this study. And the primary outcome was the composite, so death from any cause or myocardial infarction. And then the secondary was death from any cause, cardiovascular death, which is what we saw with beta blockers years ago, MI, and then different types of hospitalizations. Drum roll for the results. You can all read that, right? No, this is a summary of it. 8% risk of death, or MI, all results non-significant. So we saw no benefit when we actually looked at this in a prospective manner of using beta blocker or no beta blocker following a myocardial infarction in patients with preserved ejection fraction. Those of you that are more graphically inclined, you can see the lines do not separate. So the benefit usually of having a student or a resident on rotation is you can ask them to dig in the appendix for you, right? Because it's like, who wants to look at S1 and S2? so Caitlin and I, we dug in the appendix. Unfortunately, this wasn't one of those times where I was like, oh, eureka, I found something. But they did actually publish their subgroup data, and they kept on pointing out like, oh, there was no difference in subgroups. I was like, well, what were your subgroups? And so they looked actually at age, they looked at hypertension, they looked at diabetes, previous MI, type of MI, so STEMI and NSTEMI, and they saw no difference across. The only group there was a signal towards a difference was patients who were admitted already on a beta blocker, but the authors and actually subsequent reviewers have said that that was probably just a chance of finding. What impacted this was actually that the study did not have the event rate that it anticipated having. The authors thought that the beta blocker group would do better, and so the trial was actually ended up being smaller, which is okay for our primary outcome. They still met power for that, but when you start looking at subgroups, a little less firm with that information. And so while they say there was no significance, I'll be curious to see what comes out after this. So some final notes on reduced AMI as we kind of take it home here. So this is not definitive evidence, but it is a step in the right direction. We do have a couple issues, the open label, the no placebo design, but overall still a strong trial with some great evidence. There was a lot of crossover, which is interesting. Patients who were not on beta blocker ended up being prescribed beta blocker, and patients who were on beta blocker ended up having it discontinued. And so the level of discontinuation is worth noting, but likely did not impact the final result. So just at least something to note. All right. This does add to the guideline recommendations. This is just a snip from a slide earlier, so you don't need to read that. But that lower left-hand one with the non-randomized, I'll be curious to see what happens with the next guideline iteration. But we need to be able to practice between guidelines. We need to follow current literature that's coming out and respond to it appropriately. There is more gaps to fill, but luckily in the next 2 years, we'll have a lot of answers. I feel like that's always like there's more studies coming, but I love some of these acronyms. There's the BETA-ME, the Reboot, Dan Block, Abyss, Abbreviate, some great ones there. So that's actually going to look at beta blocker use post-MI and mid-range and reduced post-PCI. If we start looking at these kind of subpopulations, we really can then hammer down who's going to benefit from this medication and who can it be revisited in. So the reason we talk about this today, when we look at the reduced AMI study, there was no difference in tolerability between the two groups, right? So I think some people walk away from there like, well, yeah, like they're fine. These patients are doing okay in beta blockers. They're tolerating it just fine. These are good medications. They're inexpensive. Unlike a lot of other pharmacotherapy, they are available. They're in every pharmacy. There hasn't been a shortage of metoprolol since 2009. And so they do have indications, but we pharmacists know more than other disciplines that, sometimes pills can cause ills. And I work with beta blockers a lot, and I'll point out the one on the left. So exercise intolerance. There's actually a really lovely Medscape kind of like review of they call it like the tyranny of beta blockers. And they talk about these patients who go into like CV rehab and they can't get their heart rate up. They get chronotropic incompetence where their heart rate just can't rise. They can't meet the needs of the exercise and they become intolerant of that. And so if we're able to reduce that pharmacotherapy in a patient who actually has some of these side effects, geriatric patients with dizziness, tiredness, all these things, potentially we can reduce, some concerns with both polypharmacy and with side effect management. So our deprescribing considerations for beta blockers are, is there a clear indication? I really hope after this first part of our presentation today, you have a more clear understanding of what are some of those slam dunk indications where then, we talk to that patient and we say, there is a really great reason you're on this medication. This medication might actually be keeping you alive, low risk of CV death, might be keeping you out of the hospital. But there's also non-cardiac indications we have to be aware of, which muddies the waters a little bit. Luckily, a lot of those are non-selective beta blockers, but a lot of those first questions to a patient can be, who prescribed this? How long have you been on this therapy? Was it around the time you had, an MI, or was it something else? And so we do need to kind of be very clear about what are the indication of the medication being used. And then secondly, are there any additional benefits to deprescribing? So is there significant polypharmacy, which could be like another reason to do it, another reason to contact the prescriber? And is the patient experiencing any side effects? Now, I didn't fill in current dose here, but can anybody like shout out like why is current dose important when we think about deprescribing a beta blocker? What happens if we stop metoprolol 100 milligrams? Tachycardia. I heard it up front. Nice work. So we do get rebound risk of tachycardia. You might get some hypertension, although it's less likely unless it's a non-selective beta blocker. But this is also where we can have an active role. There's some recommendations out there. There's no clear standard for tapering beta blockers, but about a 50% reduction every 2 to 4 weeks is what's been recommended by some of the geriatric societies. And so that can take, a month or two. I have done it faster. I've certainly have done it faster and patients have tolerated it, but just to know, some of those patients really want to go slow with it and we can monitor appropriately. So like I said earlier, and this is kind of my soapbox, we are a catalyst in these discussions. This is shared decision-making at the core for prescribing appropriate pharmacotherapy, but then being aware of literature and actually deprescribing and revisiting. So it is always a benefit risk discussion. It should always include these parties. And we do need to kind of put our heads together and be able to advocate for patients in this way. Like I said, this is independent of setting. Everywhere you practice is going to experience some level of deprescribing. So let's go back to Ken. So we look at Ken with his CV flag on there, and we ask Ken a few questions. We ask Ken, does he have any other indications for that beta blocker? And he's like, no, I started it right after I had my NSTEMI or myocardial infarction or heart attack. And then we also need to look at Ken's ejection fraction, right? And so if Ken's ejection fraction is preserved, then I would firmly believe this is the type of patient where this could be revisited. Metoprolol 25 milligrams is a starting dose. You can cut metoprolol, so we could actually have it and have the patient do that for a period of time. He's monitoring heart rate and blood pressure at home. We can check that for a week or two. But this is a great example of someone who, that beta blocker probably has never been revisited. And if we can kind of give that patient something where like he actually got rid of something at age 74 versus just add, which is what patients feel like sometimes, then we're doing a really good thing for Ken. All right, I'll pass it over to Caitlin.
Thank you, Jonathan, for walking us through the shrinking role of beta blockers. And now we're going to switch gears a little bit to talk about aspirin deprescribing. And the literature that we referred to today came out a little bit earlier than Reduced AMI, so some in the audience may have some experience with aspirin deprescribing. So we're going to go ahead and get you talking among your groups for the Think, Pair, Share activity for some active learning. We'd like you to discuss accepted indications for low-dose aspirin, as well as to discuss scenarios where aspirin might not be indicated. And as you're talking, feel free to share about your clinical experience in this area. And I also challenge you to think about some cases or scenarios where it might not be so clear whether we should continue aspirin or potentially deprescribe. So I'll give you a few minutes to discuss. Sounds like there's been some really great discussion, and I hate to cut it off, but thank you so much for your participation. We'll kind of bring it back to the main group now. And you had a chance to discuss amongst your small groups, but it's also nice at a conference setting to kind of see what others in the room were thinking about. I didn't set up any polling questions, but basically just by show of hands, I was curious to know if you might be able to raise your hand if this applies to you. You don't have to share anything, so don't be afraid to raise your hand. But just by show of hands, how many people are impacted in their clinical practice or have previous experience with aspirin prescribing or deprescribing? Great, so quite a few. Just adjust my mic there. Excellent. And whether you have past clinical experience or not, based upon your discussions, how many people found aspirin prescribing or deprescribing to be pretty straightforward and simple? Not very many hands at all, maybe some for certain indications. Which groups were able to discuss an opportunity where it wasn't quite so clear whether we should continue that aspirin or potentially deprescribe it? Sounds like many were able to. And in my practice as a primary care clinical pharmacist in the AmCare setting, that is certainly the case. So with today's presentation, my goals are to walk through the evidence that we have available to us and recent literature and guidelines, and then walk through a 4-step approach for looking at deprescribing of aspirin. So to walk back in time, we would start briefly with the introduction of aspirin as a medication, which was first produced in 1897. On this timeline, almost 100 years later, There were multiple clinical trials where aspirin was used in patients who had a past history of cardiovascular disease. And these trials showed benefits leading to the widespread acceptance of aspirin for secondary prevention. And that hasn't been disputed since. But in order to safely deprescribe, we do have to have a great understanding of what is meant by secondary prevention. So to review some of those conditions, we have patients who have a history of myocardial infarction, revascularization procedures such as PCI or CABG, stable or unstable angina, stroke, transient ischemic attack, peripheral arterial disease. These patients should be on aspirin in order to prevent a second cardiovascular event. We can think of this as a slam dunk indication. But when actually in clinical practice, it might not be so easy. When you're reviewing a patient's chart, these indications may be buried instead of right there on the problem list. And they may be phrased a little bit differently as well, such as chronic coronary disease. That doesn't explicitly get listed on here, or stable ischemic heart disease. These are just different ways to name similar things. So it's really important to involve prescribers who are involved in the diagnosis of such conditions to confirm if there is a true diagnosis or indication or an opportunity to deprescribe. To add a further layer of complication to that, we also can think about the patient who is already anticoagulated on warfarin or a direct oral anticoagulant for another purpose. Should they continue aspirin, or are they already sufficiently anticoagulated with their other medication? And this could be a topic all on its own at the conference. We don't necessarily have time to get into all of the nuances here, but I still wanted to include a reference slide because these conditions many of them have an associated guideline. So then you can look into that guideline and say, does this patient in front of me match this clinical picture, and is there an opportunity to deprescribe or not? But sometimes we have conditions where there isn't a nationally recognized guideline, as shown on the bottom there. There may be some institution-specific preferences, and so involving those prescribers is a really important part. It's really a collaborative decision, especially when there's cardiac history involved. So going back to our timeline after the secondary prevention trials, then we started looking into aspirin among people who didn't have a history of cardiovascular disease, known as primary prevention trials. And past iterations of guidelines, which are shown here, and I won't read all the details, but they were basically recommending aspirin for primary prevention based upon certain age and ASCVD risk criteria, as long as people didn't have an increased bleeding risk. Because in those primary prevention trials, it did show a reduction in myocardial infarction and stroke. It did not show a mortality benefit, but then also there was an increased risk of bleeding. However, these guidelines were called into question when 3 major clinical trials were all published in 2018. They looked at aspirin versus placebo in primary prevention, and they have abbreviations called ARRIVE, ASCEND, and Aspirin. You've probably heard of these. So we're just going to very briefly go over this literature. ASCEND was a trial of over 15,000 adults who had diabetes. And based upon the relative risks shown here, aspirin, 81 milligrams reduced cardiovascular events by 12%, but also increased risk of major bleeding by 29%. And that led to a number needed to treat of 91, closely followed by the number needed to harm of 111, though. Then we have ARRIVE, another large trial over 12,000 adults with moderate ASCVD risk who did not have diabetes. And then we actually saw that there was no reduction in cardiovascular events when looking at the statistical significance, but the hemorrhagic events for the safety endpoint doubled in the aspirin group. And this led to a number needed to harm of 196. And then finally, we have Aspirin, which was almost 20,000 individuals who were elderly adults taking aspirin versus placebo. And for the efficacy endpoint of disability-free survival, again, we did not see a benefit when taking aspirin versus placebo, but the individuals taking aspirin when looking at the safety endpoint of all-cause mortality actually had an increased risk of death by 1 to 29%, leading to a number needed to harm for mortality of 140. So these 3 major trials, in summary, reduced the amount of benefit that we consider for aspirin in primary prevention than we previously thought, and it also shed some light on the fact that aspirin is not a benign therapy. It can cause bleeding, and if there is no true indication, if there is 0 benefit, then any risk is going to outweigh 0 benefit. So then we have lessening of how strong the recommendations are and in which individuals it's recommending. So after 2018, we have the 2019 ACC-AHA primary prevention guidelines recommending low-dose aspirin in primary prevention among select adults age 40 to 70 years who are at high ASCVD risk but not giving a certain cutoff criteria, and then who are also not at increased bleeding risk since that's a known risk. And if we continue that timeline picture farther, we get to 2022 United States Preventive Service Task Force, or USPSTF. I put a gold star here because in my own clinical practice, this is what I'm typically listing in my clinical notes when I am making the decision to start someone on aspirin for primary prevention. And USPSTF suggests that for adults age 40 to 59 with a 10% or higher ASCVD risk, then the discussion may be appropriate to have or start to look into, is this someone who I would start aspirin on for primary prevention? But ultimately recognizing that the net benefit is expected to be low. And the person who is most likely to benefit are those at low bleeding risk and those willing to take the aspirin for an extended period of time. And the USPSTF also recommends that for adults 60 and older that we shouldn't be initiating aspirin for primary prevention, but keep in mind that the opposite of this is not necessarily a deprescribing recommendation. So this is not saying that as soon as a person turns 60 years that then we deprescribe aspirin, because they may have very well recently met the above criteria if they have really high cardiovascular risks and a shared decision was made to start the aspirin for primary prevention at that point. Then, in that particular case, USPSTF cites some modeling data suggesting that discontinuing aspirin for that individual around age 75 is approximately a time to be thinking about that. And as you can see, the level of evidence, grade C and D, are a little bit lower on the scale too, because we don't have as much strong evidence for primary prevention. And then other clinical guidelines also make comments on aspirin for primary prevention as well. So the 2023 Beers criteria discourages initiating and recommends deprescribing aspirin for primary prevention in older adults. And then the 2024 American Diabetes Association guidelines suggest that it may be used for primary prevention among those with diabetes, but based on an individual risk versus benefit discussion. So what does that actually mean, and how can we apply this concept to an individual patient sitting in front of us? Well, we would start that discussion by looking at their cardiovascular risks, and there is not one single way to do this. There are risk estimators such as the AHA Prevent calculator that came out last fall, or the Aspirin Guide app may be a tool that some of you have used. Most commonly or most well-known might be the 10-year ACC-ASCVD risk estimator, which includes risk factors such as age, sex, race, blood pressure, hyperlipidemia, diabetes history, as well as smoking history. And then family history of premature ASCVD is not included within that risk calculator, but is a known risk factor for heart disease. There's also some growing evidence for other factors that may be markers in the future to help us decide who is the ideal patient for aspirin, but more to come here. One of them is the CAC score, or coronary artery calcium score. On a recent systematic review of 4 trials, it found that there was net harm for aspirin if the ASCVD risk was below 5% or low risk, regardless of what the CAC score was. But 3 out of those 4 clinical trials found that there could be a benefit for aspirin in primary prevention when ASCVD risk is higher than 5%, and the patient is at low bleeding risk, and their CAC score is 100 or higher. So potentially a marker more to come in the future. Lipoprotein A is another one that has been not necessarily focused the study on lipoprotein A, but as secondary analyses in previous trials, there is some suggestion that when elevated above 50 milligrams per deciliter, that possibly that can point to a patient who might benefit from aspirin, but really more trials are needed specifically focused on this marker. And then we weigh that against bleeding risk. Again, there is no one single way in order to assess bleeding risk. HAS-BLED is just a mnemonic that kind of sticks in my head. But then the 2019 ACC-AHA primary prevention guideline will list slightly different bleeding risks, as well as the 2022 USPSTF recommendations. So one thing that's interesting is hypertension is listed as both a cardiovascular risk on the previous slide and a bleeding risk. And then some of the commonalities among the lists shown here for bleeding risk would be people who have chronic kidney or liver disease, past bleeding history, who are elderly or are taking certain medications that increase bleeding risk, such as NSAIDs, anticoagulants, steroids, and alcohol. And then we get to points where we have an opportunity to potentially deprescribe aspirin. So these are points as these might be coming up in visits. If patients are reaching an advanced age, or maybe their bleeding risk or fall risk is increasing because they had a new fall or something like that, where the pharmacist is able to identify and assess that risk. In ambulatory care pharmacy, which is my practice, I particularly have an opportunity to focus on that middle box there, controlling the other cardiovascular risk factors. Because if we can lower A1C, and if we can control blood pressure, lipids, and help the patient stop smoking, maybe we've reduced their risk so much so that it promotes the opportunity to deprescribe that aspirin. It's not providing as much benefit anymore. If a patient has a change in life expectancy, such as if they go on hospice, then the primary goal may no longer be to prevent that primary event. And then when there are changes in evidence or clinical guidelines, as we've been able to review with the timeline earlier, this is another opportunity to use our expertise as pharmacists to know the literature, to communicate that with patients and healthcare teams. So now we can walk through this with a patient case, and this is where I'm going to point out that 4-step approach for looking at aspirin deprescribing. So I'd like you to meet John, who is a 58-year-old male who has type 2 diabetes, hypertension, hyperlipidemia, and was a former smoker. And his relevant family history is that his father passed away due to an MI at 54. His medications are listed here, including aspirin 81 milligrams daily. And today his blood pressure is elevated, and also his A1C is high, LDL is elevated, and he has a 10-year ASCVD risk of 12.8%. The first step in our approach is going to be to review the past medical history for aspirin indications. It's really important to not miss that. But for John, we see that he does not have a cardiovascular disease history. One strategy that we may use is to kind of compare his clinical picture to the 2022 USPSTF guidance, again, which is for initiating aspirin for primary prevention, but it can just be nice to see, is this a patient who came to me without aspirin? Is it someone who I would recommend prescribing aspirin for primary prevention in the first place? So when looking at John's clinical picture, he does meet those age and cardiovascular risk criterias. So an individualized decision can be made and had with the patient, but ultimately recognizing that net benefit is expected to be small, and those most likely to benefit are those not at increased bleeding risk and willing to take the aspirin daily. Step number 2 is going to be that individualized assessment of his cardiovascular and bleeding risks. So for John, cardiovascular risks are the type 2 diabetes, hypertension, and hyperlipidemia history, as well as the family history of cardiovascular disease. And bleeding risks are hypertension. But these can't just be the only factors that we weigh, and also they're not necessarily in a 1-to-1 ratio. If we get more cardiovascular risks versus bleeding risk, that's not an automatic indication. We do have to incorporate discussion with the patient and then really discuss all of the benefits versus risks. So one thing with John, since he has diabetes, we could cite the ASCEND trial with him, and we could talk about how cardiovascular events were reduced by approximately 12%, but that was also balanced against the fact that we saw a 29% increase in major bleeding in that same clinical trial. Another risk or downside to continuing the aspirin would be that there is a cost, even though it's low, but it does add up. And then pill burden. So again, polypharmacy, if that's something that we're trying to get rid of, this could be an opportunity here. Then we still have to get more information from that patient. We can't review just solely from the chart, but we have to ask some more questions. So for John, I would be interested in asking more about that former smoking history. Let's say he stopped smoking 20 years ago, which has certainly reduced his cardiovascular risk much more so than if he had stopped smoking 20 days ago. That would be a different clinical picture. And then getting an accurate medication reconciliation is important. For John, we actually learned that he is taking ibuprofen, 400 milligrams, 4 times a day for chronic pain. And that's definitely a bleeding risk that we're going to add to our risk versus benefit discussion, since NSAIDs can raise the bleeding risk. And next we can look at how can we reduce the cardiovascular risk? Again, to tip the scales, is this a clinical picture where aspirin deprescribing may be the outcome? We could work on blood pressure, A1C, and lipids in order to reduce that cardiovascular risk. And the patient's preference is really going to weigh into all of this. So any patient situation can go in multiple directions. For example, if John had told us that continuing that aspirin is very important to him because he has that family history of heart disease, then it may be something where we do continue the aspirin for primary prevention, but we're definitely counseling on the fact that the bleeding risk associated with the NSAID is important to recognize, monitor, triage appropriately, or to see if we can stop the NSAID and control pain in another way. Or maybe John comes to us and says that he's happy to work on diabetes and blood pressure control because he knows that will help reduce the risk of heart disease. And if controlling these other risk factors allows him to stop one of his medications, then maybe he's happy about that. So this could lead to an opportunity to deprescribe aspirin. An important note that I recognize in my own clinical practice in ambulatory pharmacy is that it takes some time to control A1C and it takes time to get to blood pressure goal. So if we're able to eliminate the bleeding risk, get that NSAID out of there, we may continue the aspirin while we're working on some of those other risk factor control measures. And then once we achieve those goals, then consider deprescribing at that point. But for the purposes of wrapping up this patient case, let's say we go ahead and we're planning on deprescribing aspirin. Then we have to make that recommendation to the healthcare team or collaborate. And not only can we recommend to deprescribe aspirin, but we can also discuss pain management strategies to reduce the NSAID use and lower bleeding risk in that measure. We can also optimize his statin and work on controlling hypertension and diabetes as well. However, deprescribing aspirin is not without its challenges. There is change in evidence, and this applies for beta blocker deprescribing as well, but there's changing evidence and clinical inertia can be a problem. If we've always practiced this way and a certain healthcare professional isn't aware of the changes or maybe just hard to change, that clinical inertia can be an issue. We also have multiple clinical guidelines that are weighing in on this, and some of them more or less clear than others. Unclear chart documentation, as we've been talking about, it can really be a buried indication somewhere that we might miss, or unclear on what the true diagnosis is. Patients can also resist our recommendation to deprescribe aspirin. They may consider it something that they've always done and don't perceive the harm. So if we can educate on that and really make sure that it's a patient appropriate discussion, that's really recommended. And then finally, with aspirin being available over the counter, it may be a medication that our patients are taking that we don't even know about. So it's important to do that medication reconciliation. Ultimately, all these challenges point to the fact that we do have to collaborate with the interdisciplinary healthcare team and have great communication for shared decision-making with patients. Today, we've been able to walk through a single patient case, but across the state of Wisconsin, pharmacists are making a really big difference in aspirin deprescribing initiatives. Here are 3 recent publications, all within the state of Wisconsin, where pharmacists are leading this. And then at Freighter, we haven't had a recent publication, but I know our anticoagulation team has partnered with the AC Forum and is working on an aspirin deprescribing project specifically for those who are already anticoagulated. Seems like there's promising results there, but it's not yet published. Whether looking at beta blocker deprescribing or aspirin deprescribing, in summary, this is going to require knowledge of the literature and guidelines, appropriate assessment of indications, individualized assessments of both risks and benefits for that patient in front of you. And ultimately, to do that safely, we have to discuss with the patient and also collaborate with the healthcare team. So with that, we really appreciate your discussion and participation in our session today. As we pull up the CE code, we'd also like to open it up for any questions. So feel free to raise your hand and share a question. Thank you.
Yeah, that's a good question. I'll repeat that. So there are other beta blockers out there. There's been some more recent additions, like nebivolol is a good example. And as those therapies, they came on, I believe it was, correct me if I'm wrong, but nebivolol, I'm pretty sure was one that did not show benefit in heart failure. And so it kind of like spun out a little bit. And some of them have had that when they come on, they're like, oh, we've got this other benefit. And then it just doesn't ever bear out. It's one situation where I do kind of point to the CCD guideline that came out last year where they really focused on metoprolol, succinate, carvedilol, and bisoprolol. I do think there are indications for those, absolutely. But that's where I probably try and follow the data for that specific beta blocker, and if it exists. Because if it's going to break down a barrier for cost for a particular patient, like I'm all in favor of that. Sure. Yeah. When you've seen nebivolol, like, has there been any other like comorbidity that they're prescribing it for?
Not. It's the same. I think it's just the story.
Yeah.
Now, while you're switching to it, and
Yeah, no, that's actually that's kind of where I've seen it too. Because it did kind of burst onto the scene, but yeah, when they didn't show that benefit in heart failure, I started seeing it being peeled away. Good question.